Good afternoon, everybody, and you're very, very welcome this afternoon to the European Institute of Women's Health launch of its report, Women in Europe Towards Healthy Aging, Midlife and Older Women's Health. And before I pass on to our host for today, Sirpa Pietikäinen, I would like to just give you a few housekeeping tips for today. Could all speakers remember to keep all their cameras and mics muted? And if you have any questions, place any questions in the chat function. The speakers will see your questions. This meeting is also recorded. I'd just like to tell you that the chairperson for today, I'm delighted to say, is Maeve Cusack, who is a board member of the European Institute of Women's Health. Maeve is a general manager with the Irish National Cancer Screening Programme and extensive experience in healthcare settings, both in Ireland and international. She's also a member of the WHO Academy Equality Committee. Working as part of a multidisciplinary team, Maeve played an integral role in supporting individuals in hard-to-reach groups to participate in the national screening programme, which she also had a position of manager within the National Cancer Screening Programme. So thank you very much for joining us. And without further ado, I would like to hand over to our host for today, Sirpa Pietikäinen, who has a long established relationship with the European Institute of Women's Health. Sirpa is an MEP, she's from Finland, and has considerable amount of effort on behalf of people in Europe for advocating for better health, among other social determinants of health. She is Vice President of the Council of Alzheimer's Society of Finland, and she's also a member of the a substitute member of the Environment and Public Health Committee. Sirpa, I would like to welcome you to the event, and please take the floor.
Peggy, I'm not sure if Sirpa has come into the meeting yet. Perhaps we can move to oh, here she is. Sorry. All right. Sirpa, you're just introduced there.
Oh, thank you. I thank the organizers of this report wholeheartedly for bringing up this very important and timely matter. And I'm very eager but saddened out of the results. And I think that this is a topic we should be taking up more and more in part of the EU's health union and the preparation of it. And I won't go and I won't dwell in detail of the report, because we do have the possibility to hear a proper introduction of it, and also the proposals how to go forward. But what I would like to draw is the fact that we have discussed about the bias against women in healthcare for quite a long time. And this goes both in understanding that the gender, that the sex has an impact on the impact of medicine, on the symptoms of diseases, and the prevalence of different diseases in different sexes. And of course, this is very important throughout our whole life, starting from the childhood or developing to be girls and boys and in betweens. And this is, of course, important in maternal health care, for example. But the older we live, the greater the bias actually comes, both by the positive fact that women live longer and they are quite often undiagnosed. The prevalence of female typical diseases are under-resourced, and it is still unknown how the different diseases, like different forms of diabetes, actually takes the onset and gives the symptoms in different sexes. Plus then, given that women are the most frequent users of healthcare and they are not the best treated ones, is a human rights issue. Secondly, the known fact that the medicines have different impact, starting from stem cells on, depending our sex. It is still utmost outrageous that we do not have adequate gender-sensitive testing and follow-up on different medicines and care methods. So there's a lot for us to work together on. And as said, I'm very grateful for you to take this initiative and providing this remarkable report to be presented for us and as a stepping stone for our further political activities in this area. Thank you.
Hello, thank you very much, Sirpa, for that. And this is Maeve Cusack here. I think I know most of the participants, and it's really great that people can join the group today. And I'm saying, you know, this the whole webinar, the technology of it, but I'm really looking forward to the presentations. And just to start off with, we have Teresa Keating. And Teresa is an independent researcher who has completed the update of the Midlife and Older Women's Health Report. And we really appreciate Teresa's contribution and commitment to the report and to other research that she has completed with the Institute. So I would like to hand over to Teresa now, and she has her slides to the ready, hopefully there, and we can move on with the webinar. Thank you very much.
Thank you, Maeve. And Tom, if you could just put up my cover slide, that would be great. Thank you. And good afternoon, everyone. As Maeve said, my name is Teresa Keating. For the past 20 years, I've been working in health research and policy, focusing in particular on social determinants of health and health inequalities. And I'm delighted to be here today to give you a very brief overview of this paper. The aim of it is to draw attention to the challenges particularly faced by women as they age across all EU member states. Just to say that the European Institute, of course, supports a life course approach, so is concerned with girls and women of all ages. But for the purposes of this paper, we're focusing our attention on women who have already reached middle age or older. Next slide, please, Tom. Could we move on to the next slide? Thank you. So just to give a brief an overview of what I'll be presenting today, and this follows the outline of the paper. I'm going to touch very briefly on some issues around causes of death and illness in this cohort, and then look at some of the factors affecting women's health in older years, touching on employment and financial resources, and then healthcare access to an experience of healthcare. The report identifies 7 priority issues. Today, we're just focusing on the first 3: cardiovascular disease, cancers, and mental health and neurological disorders. The others, unfortunately, we don't have time to go into in detail, but they are covered comprehensively in the report. Just draw your attention to the last one there, vaccination. When we scoped out this report, it was in a pre-COVID era, but with all the changes that have come about in the last 18 months, we have added a section on COVID as well and COVID vaccination. And I'll conclude then with some steps for action, which I hope will open the floor for further discussion. Could I have the next slide, please? So to start, just to say there are a number of graphs that I'll be presenting today. I realize they're very busy, a lot to take in, and I'm just going to pull out a couple of key points from the slides, but they are all in the paper. All the slides are presented in more or less the same way. So the EU 27, for example, the average will always be on the first column or the far left. So here we're looking at the proportion of deaths caused by the 2 main causes of death in women aged 50 and older. That is cardiovascular disease, which across the EU accounts for about 41% of all deaths, and cancers, which account for a further 23% of all deaths. So just over a third, about 36% of deaths in this cohort are by all other causes. That's the EU average. But if you just glance across all the member states, you'll see quite remarkable differences. If I can draw your attention to, for example, in the third column there, Bulgaria, it's coming in at about 70% of deaths from cardiovascular disease. That's almost twice as high as the EU average. Whereas in contrast, if you look at Denmark, just 2 further over, about 22%. Now, this raises far more questions than it answers, which we won't go into just now, but I hope it will stimulate some debate further. Next slide, please. Could I have the next slide? Thank you. So here we're looking at the percentage of women reporting one or more chronic disease. And here I've broken it down into, if you like, midlife, which is in the blue column, and older age, 65 plus, in the orange column. And again, you can see the EU average, about 40%, or 2 in every 5 women in midlife are reporting at least one chronic disease. And this rises to 3 in 5 amongst those age 65 and older. And again, you can see significant differences across the EU member states, not only in varying from the EU average, but also in differences between, for example, in Greece, you can see that less than 20% of the middle-aged women are reporting chronic disease, and this triples then to about 60% in older ages. So again, lots of variance across the member states. Next slide, please. And so I'm going to just turn now to some of those factors, the causes of the causes, if you like, of ill health and death. And here I'm just picking up on indicators, differences between women and men on indicators for work, money, and time. And of course, employment, financial resources have significant effects on independence, on health and well-being in women. And you can look here at a glance, no matter which indicator you pick, there are significant differences between men and women of working age. So if you look here, full-time employment rate, 42% for women, 57% for men, and flexibility in working arrangements, 23% of women, I beg your pardon, compared to 27% of men. And of course, work and money being closely related, those mean monthly earnings for women are about €600 less per month for women than for men. The final indicator, time, is looking at that work balance between paid employment and unpaid work. So you can see significant differences between women and men. On average, 38% of women are caring for others every day. Now, this could be children, it could be elderly parents or others, compared to about a quarter of men. And at the same time, about 4 in 5 women are cooking and or undertaking housework every day, in addition to their paid employment, compared to about a third of men. Could I have the next slide, please? And then looking at access to and availability of healthcare. And this is divided into 4 groups. So the blue column on the left is middle-aged women. The next column, the orange, is middle-aged men. Then the grey is women aged 65 and older, and the red is men aged 65 and older. And you can see here at the EU level, the drop, the difference. So far more middle-aged women than middle-aged men are indicating that they have unmet needs for healthcare. And there is a similar difference then between older women and older men. And that pattern is more or less replicated across the EU in most, but not all cases. But there are significant differences in the percentage of people reporting in each of those 4 groups. Next slide, please. And now I'm going to touch on 3 of those priority issues that I mentioned. So looking first at cardiovascular disease, the standardized death rates, and again, this is the leading cause of death in women aged 65 and older across the EU, accounting for about 1,500 deaths. Again, huge differences between countries. If you look just 2 down at Bulgaria, almost 3 times the EU average at almost 4,500. Looking at France, then it's well below the EU average, coming in at around 700, around 750. And next slide, please. And again, looking at standardized death rates from cancer. And here I've divided into three leading causes of cancer deaths amongst women. And that is breast, that's the blue, orange is lung, and grey is colorectal. Not very significant, although breast is the leading cause, closely followed by the other two at the EU level. But again, if you look across the member states, one that really remarkably catches my eye is in Denmark, very, very high death rates from lung cancer in particular. And indeed, that pattern is reflected in many other countries, with lung cancer being the leading cause of death and not breast cancer. And next slide, please. And following in that vein, then this is just looking at public cancer screening programs. So this study looked particularly at public programs that were available to the whole relevant population. So some people might be surprised at the gaps in some countries which do have cancer screening, but didn't fit the criteria for this particular study, which was looking at publicly available. And there is no EU average for this slide either, because of the way the study was done and the gaps. But here again, you can see, so blue is breast cancer screening and orange is cervical cancer screening. And here you can see again, remarkable differences in the percentage of the population that's actually reached. And in some countries, let's say it's not actually there at all. Other countries may have, for example, breast cancer screening, but not cervical, like for example, Cyprus. Next slide, please. And now I'm going to turn to the third and final priority issue, which is standardized death rates from mental and neurological disorders, again, among women aged 65 and older. And here, this is divided into, in the blue column, mental and behavioral disorders, and in the orange column, neurological disorders. This excludes stroke, which is covered in the cardiovascular disease slide. And you can see EU average, very similar between the two different types of disorders, but again, significant differences, both in overall death rates, but also whether one is higher than the other. And there is quite a lot of variance, as you can see. So you may have seen a pattern emerging where in some countries, the death rates are very low. And this may be because in those countries, women are dying at much earlier ages from cardiovascular diseases and cancers. Or it may be the fact that the diagnosis is not there. So there's, again, lots of questions to be asked about what these data actually tell us. Next slide, please. And looking then at standardized death rates from dementia and Alzheimer's among women aged 65 and older. And again, you can see dementia in the blue and Alzheimer's in the orange. At EU level, the death rate is higher from dementia than Alzheimer's. And this is reflected in most, but not all countries. But again, very, very big differences throughout. And next slide, please. And finally, then the percentage of women reporting chronic depression, and this is divided by age group because there are some differences. The blue is the midlife and the orange is the 65 plus cohort. You can see in almost all countries, older women, that is women aged 65 plus, more likely to report chronic depression than the middle-aged women. And again, differences, my eye is drawn to Portugal there, which has very, very high rates in comparison to the EU average, coming in at about 2.5 times for both Alzheimer's, for both middle-aged and older women. And next slide, please. So that's a very brief whistle-stop tour. I appreciate a huge amount of data to take in a short period of time. But what I want to finish on now is just to touch on some steps for action. But in this slide, in fact, what I'm showing is the recommendations from the 1996 report. I should have said this at the start, I don't think it was actually mentioned, but the first piece of work that the European Institute did in 1996 was in fact a report looking at the state of older women, midlife and older women's health across the EU. Now, of course, as we know, 15 member states, then 27 now. But what's remarkable when we look back at the recommendations from that report is many are still relevant even today, 25 years later. Now, that's not to say, not to ignore all the good work that has happened in those intervening years, but I thought it was worthwhile just to pull up 4 of those in particular that, as I say, are still absolutely relevant here today. And the first one is looking at to adopt a coordinated effort to ensure the prolonged health, well-being and independence of midlife and older women. So much work has been done on gender inequality, so much has been done on aging. And I think the challenge now is to bring those together. In the case of midlife and older women, the 2 issues combine and in fact compound. Second issue there, the second recommendation was to focus on health promotion. As ever, that is always going to be relevant to help conserve limited resources for healthcare treatment and diagnosis. To set time-based achievable targets for reducing the incidence and severity, and I'm using the language of the 1996 report, coronary heart disease, cancer, osteoporosis, which is covered in the 2021 report, and depression in each member state. And you can see there's such between the member states in all these issues. And finally, as ever, data. There is so much data available now, but there is still a need to make sure that information is coordinated and that we can raise standards throughout the EU. And I can ask for the next slide, please. So finally, these are the recommendations or the suggested steps for action from the current report. And I'm going to finish on these. There are many more in the report, but I just pulled out 4 here, what we're calling for. Gender responsive health services. And indeed, Sirpa mentioned this in the context of the new clinical trials directive, and it goes much wider than that as well, in that there is a recognition from all healthcare professionals of the need to look at the sex and gender issues relevant to women and of course to men as well. I very briefly touched on gender equity across work and pensions, and I know a lot of work is ongoing on that. You could see in one of the earlier slides I showed the differences, which of course are well known. Just to say that the work that's happening now, of course, is beneficial. It is more beneficial to younger women, those that have already reached midlife or may indeed be retired, have not had a chance to reap those benefits. There is absolutely still a need for action at EU level on mental health. You can see several of those slides at the end, we were focusing on mental health. It is such a key issue. And finally, there is always a need for better quality, timely data. The data is excellent. It does take a long time, and in our rapidly evolving world, sometimes the issues that the data is showing are already almost out of date. And the second point there, more data needs to be disaggregated by age and sex so we can hone in on the particular issues in more detail. So I'm going to leave it there, and thank you very much for listening. I'd like to hand back to Maeve now.
Hello. Yeah, thank you so much, Teresa, for that really comprehensive summary of the report. And I know people have probably lots of questions, and it's really great for even discussion triggers. But just to say to people as well, you can use the chat function as well if you have comments, and we will, if we don't get back to everybody today, excuse me, we'll be getting back to the group after this webinar. But just to say to yourself, Teresa, that was really, really interesting. And I know that just a comment really, I suppose the whole area of the health promotion, you know, has been a challenge, I think, in terms of efforts to impact on influence different levels of society across the EU states. I mean, it always has. I think post-COVID, that'll be another challenge, you know, and the whole area of screening for myself, just having that interest in that area and the data. The programs I know that are run nationally have stalled and paused in many countries, and I'm sure that'll impact on the date as well in 2022-23 going forward. But just to ask people if you have any questions, if you want to raise hands, or if there was any significant questions there, that we will manage the chat function, or we can come back to questions later. Okay. Okay, Teresa, well, listen, thank you very much for that. Really appreciate it. And you stay, hopefully, to join us for conversation discussion later. I'd like to, if there's no more questions, I would like to invite speaker Isabel de la Mata. And I think all of you, I'm sure, will know Isabel. She's contributed heavily to so many of our European discussions at the Women's Institute. Isabel is currently the Principal Advisor for Health and Crisis Management in the European Commission. Previously, Isabel worked as Councillor for Health and Consumers at the Permanent Representation of Spain to the EU as Deputy General Director for Health and Planning in the Spanish Ministry of Health. And she's also a specialist in preventative medicine and public health. So Isabel, if I can ask you now to share your presentation with the group, I would.
Yes, I'm sharing. Can you see it?
Yeah. Yes,
okay.
Thank you, Isabel.
Okay, thank you very much. So I was requested to speak about the health program. So
Isabel, sorry to interrupt you. We need to look at you just need to switch to the presenter view. If you look at the top of your screen. We're seeing the.
At the top, the only thing that I can see is you are screen sharing.
But there should be within the program. You should be able to swap presenter view and notes view. It's just we're not seeing your. Would you like me to share the presentation on your behalf?
Yeah.
Oh,
maybe.
Sorry. Actually, there you go. See where it says display settings. Display settings on your screen.
So I stop in my screen and you will present, right?
I'll do it. Yeah, I'll do it.
Okay. So I have to stop.
Grand.
So. Okay, now everybody can see the presentation.
Yes.
Okay. So I was requested to present what the EU for Health program is, the state of play. This is the big change from previous periods from 2014 and 2020, because maybe you remember that in the past we had a program that was 460 million for 7 years, and now we have a program that is 5.1 billion for 7 years. So a lot of change, a lot of money, and a lot of new expectations and possibility. The next slide, please. So the program was established. The main reasoning for having so huge program was the COVID-19, of course. So the response to the COVID-19, and that allowed us to go for a more ambitious vision than what we had until now. That was a good news, because we were claiming for many years, and all the stakeholders, to have a more ambitious program. More ambitious also means not only, but also more funding, and with a different approach, without stopping everything that we were doing and the commitment for promotion and prevention, but that could respond better to the different requests from the stakeholders and the ministries of health. So it's the largest investment in health that we have had ever, and I don't know for the future. But probably will be the largest that we will have ever, even in the future. So will be for 2021, 2027, and will be, well, the numbers are not only completely fixed, but we say between 5.1 and 5.3 billion euros. Next slide, please. So This money, this financing is divided, or with not completely divided in the different areas, but we have established a minimum of what will be reserved for the different areas, and also a maximum. So to avoid that this program, for example, is dedicated mainly to the administrative issues, we have reserved a maximum of 8%. 8% is the maximum that could be established for financial, for covering the administrative expenses. So we have reserved also, you know, that we always said that the public health is the poor sister of the healthcare, and that only 3% of the budget is reserved for public health in the different budgets of the national administration. So we have decided that a minimum of this 5.3 billion will be dedicated to health promotion and disease prevention. So it doesn't mean that it couldn't be more, but at least will be 20%. And also we have established also some safeguards, for example, that for complementing the national stockpile will be a maximum of 2.5%, and that for supporting global commitments will be also a maximum of 12.5%. So the more administrative or funding that will not be shared with the stakeholder, that will not be really dedicated to the objectives of the program, the promotion, the prevention, and etc., will be 33%. So 1 tier and 2 tiers will be dedicated to our main worries. Next slide, please. So which one are the general objectives of the program? Well, we have clear to improve the health in the European Union, to protect the people from cross-border, serious cross-border health threats, and to improve the access to the medicinal products and medical devices, and strengthen the health system. So the general objectives, more or less, have been the same that we had in previous program. The only issue is that we have put very clearly that the main objective is to improve the health of the European Union and to protect the people from serious cross-border health threats. But I mean, it's more or less the same general objective that we have had in the last 3 health programs. The next one, please. And there will be, I mean, those were those 4 the general objective, and now we have 3 more specific objectives. And these specific objectives you can see there. It's not necessary that I repeat, but could go from prevention, complementing the national stockpiling, the international health initiative, the strengthening the health data, and etc. So has mainly 4 clear areas. So next slide, please. And there are, as in previous occasions too, different implementation means. And so the usual, the grants, that is for the project that different stakeholders present, the public procurement, the prices, and other potential but more rare kind of financing. But the most common are the grants and the public procurements, or the grants and the tenders that you will see in the next slide how we are going to divide between both. The next one, please. So there will be complementarity with other programs. So the EU for Health is not on their own. We have many different EU programs that some of them can be also dedicated to the area of health, like the European Social Fund or the Horizon Europe, the Invest EU. So it's not that all the investment on health and all the activities on health have to be just funded by the EU for Health or and established by the EU for Health. There is a list of different EU programs that could contribute to this improvement of the health of the population. Next slide, please. So we approved in March 2021 the EU for Health, so the general program for the 7 years, and then we prepare the work program for this year, because apart from the general one, we need to establish for every year which one is going to be the work programs or the priorities for that year. So we had the preparation, is the commission who does that, the consultation, the input of information, and the adoption. So and the adoption was done, next slide, in June 2021. For this year, 2021, as is the first year, and we began not in January, but only in June, we have a budget that will be inferior to next year. So for this year, only 300 million, but 300 million is nearly what we had for the whole health program in the previous year. So next one. And we have the 4 strands that are the disease prevention, the crisis preparedness, the health system and healthcare workforce, and the digital. So all the different activities that are going to take place in 2021 are under those 4 pillars. Next one. And of course, there will be a series of actions that are going to implement all the different policies. I mean, we have a new pharmaceutical strategy that we are working on. We have the Europe's Beating Cancer Plan that was already presented, approved, etc. We have the different new health legislation, and we have the fight against the COVID-19 pandemic. I mean, we are all the different activities of the EU health work program have to have a framework, and the framework is what we are working on. So for the first strand, next slide, the crisis preparedness. Well, the priorities will be mitigate the shortage of medicine, the communicable diseases, so all the clear one, the usual one, but with something added, that is the HERA, the preparation of the HERA. We have we are going to dedicate to that 100 and something million, and there will be different specific actions. There will be grants, there will be procurement, and there will be joint actions like that are already in the pipeline. The second strand, next one, please, is the disease prevention. Will be more or less the same budget, 101 million, and also with the specific actions like action grants, the joint action, the procurement, but we'll have also grants for international organizations, the OECD, the work that they are doing in non-communicable diseases, and collaborating with the WHO in the code against cancer. The third strand, next slide, that is the health system. The different priorities will go from continuing the state of health to forecasting and planning the workforce in the healthcare sector. And also there will be joint actions, grants, procurement, and direct grants to international organizations, the WHO, the OECD, the European Observatory on Health Systems and Policies. You will have the slides afterwards, so I mean, I'm just giving the main lines. I'm not entering in everything because we don't have a lot of time. So the next strand, the last one, will be the digital one, and the digital one will have 33 million. So the first one, the promotion, the crisis preparedness and the disease prevention will be the biggest ones in terms of funding, and the digital one will be less funded, 33 million, but also, next slide please, but also because there is a lot of funding in the next generation EU for this area. Next one please. The digital, there will be in this area, there will be no grants for international organizations, but there will be for the joint actions, action grants, and procurement. Next one. So the budget allocation that I said that will be divided in the different areas will be more or less the same for grants and for public procurement. There has been a lot of debate over the last year how we were moving from the first program where almost everything was for grants and less for public procurement, and we need to have a balance between both financing methods and methods of establishing the different projects. Next one, you know that the CHAFEA stopped existing with the third health program, so we created the HADEA, the new European Health and Digital Executive Agency. That was established at the beginning of the year, and that is still finding all the staff and creation, but it's going well, and will take not only the health program but all the health areas of the different programs like the Horizon and the programs managed by DigiConnect. So inside the Santé, there is a European Health EU for Health Task Force that is responsible for the programming, and the HADEA is the one that is responsible for the operational activities of the program. Next one, the first call, the first main call was launched in June, so immediately after the approval of the program, and there have been 5 open calls that the deadline was just last week for the submission of the different proposals. Next one. The different calls that were published have to be with cancer. The quality, the 4 that you can see there. So from radiation technology to the cancer information systems, to the network of cancer survivors. Next one. And for joint action and other grants, there was a first wave that was open 1st of July, and a second wave that is still open today, and will close 29th of October. So there will in the first wave there were these 3 joint action that were launched, and then the direct grant for the OECD for establishing the cancer inequalities register. Next one. Who is eligible for all these activities? I mean, all the legal entities that are established in the member states. So could be NGOs, could be national authorities of the member state. Could be international organization, and also we are still establishing the collaboration with third countries. There are several non-EU countries apart from the EEA that have shown interest on participating in the health program, and we are at this moment having meetings with them and establishing or operationalizing their integration in the health program. So this is what we have been doing until now. What will happen with 2022? Because I am sure that we are also interested on that. So we have started the preparation work for the EU for Health work program 2022 with the targeted stakeholders consultation. The results have been already presented on 10 September in a webinar that we had. The strategic orientation, the priorities will be based on the results of this initial input from the member state and from the stakeholders. And now we are going to consult the member state in the EU for Health steering group on those priorities, and we will inform the European Parliament. And then the Commission will table a draft work program to the EU for Health Program Committee, and following the positive opinion of the member states representatives, the Commission adopts the work program. As you know, that the article of the Treaty of Functioning of the European Union, Article 8 about gender equality, is one of our bases, and we take into account the rights and equal opportunities for all, and the mainstreaming of those objectives will be taken into account and promoted through the assessment, preparation, the implementation, and the monitoring of the EU for Health program. If I would like, before ending, to summarize the main activities regarding inequalities that will be funded through the program. So there will be a joint action on strengthening e-health, integrating telemedicine and remote monitoring in health and care system for cancer prevention, and also with the objective to reduce cancer inequalities across the European Union. There will be a direct grant to the WHO Regional Office for Europe to support member states in improving access to healthcare and effectiveness of health coverage, taking into account vulnerabilities of specific groups, which support that policy priority to respond to health inequalities and improve the access to healthcare. And there will be also direct grant to the OECD on the establishment of cancer inequalities registry to map disparities and inequalities between member states and region, in order to have available quantitative data and contextual qualitative analysis of the cancer situation in the member state. So this is what I can tell you about the EU for Health. I hope it has not been too boring, and you will have the opportunity to explore the slides and like that to read all the different activities. And just a call to all of you that is, I mean, the consultation has just finished, but when we have consultation to the stakeholder, please contribute, because we are taking into account what you have to say. Thank you very much.
Thank you so much, Isabel. That was a really interesting presentation, and good to have an understanding of the finance and promotion as well, which is linked into the future. Just one question about, I suppose, opportunities in terms of and support for member states to improve midlife and older women's health. Are there opportunities, I suppose, is the question, for the future?
I mean, like that, yeah. With that title, we are not going to launch any call. So, but as in previous programs, you need to find your way to that. I mean, no call is going to be called support middle-aged women health, but there will be calls about inequalities on health. There will be calls about restructuring of the health services. So there will be more general calls about promotion or prevention. There will be a lot of issues on cancer. I know that cancer is not the only health issue that women have, but that you will need to find your way through all those calls. But we are going to support the member state. There is a joint action. There will be several, but there is a joint action to support member state on addressing this lack of services, especially for cancer, but also on other areas. And you will need to introduce that the issue of women's health, gender health. You know that we are quite reluctant just to talk about women, because then immediately men can come saying, why not then? So gender disparities on health, or health gender inequalities on health.
Great. Thank you, Isabel. And I'm sure there are more questions that will come up on the QA. Thomas just reminded me there's a QA button that we can use, and that's very useful. Okay, thanks for that, Isabel. We'll move on now to the next speaker of the day. And I would like to introduce, and I'm sure again, I think a lot of you will know, Janusz Jankowicz. And Janusz is a professor of medical education, chair of the WHO Academy Quality Committee, AME Executive Committee member, and vice dean for development of education at the Medical University of Lodz in Poland. His professional interests include medical and academic professionalism, intercultural competence, and using the humanities in health professions education. So over to you now, Janusz, and thank you very much.
Thank you very much. Thank you, May, for this introduction. Let me start from sharing my screen and from starting my timer, just to be sure that I don't talk for too long. So for this presentation, I would like to focus on providing appropriate education for the health workforce if we expect this health workforce to provide proper care to midlife and older women. So thank you very much for inviting me to this meeting, because what I want to do is to show you that this educational part is really important. Let me start from drawing your attention to the fact that I will be talking about health workforce, not only about health professions, because health workforce is a much more inclusive term. And especially when we talk about women, we know how many of them are informally involved as carers, as assistants. So this is about providing education for all this complex constellation of health workforce. Of course, there is one more issue that is important when I start talking. This is the fact that very often when we talk about strengthening the health systems, both from the organizational and financial perspective, we forget about investments in providing the health workforce with the appropriate lifelong learning opportunities. And in fact, I'm very happy to speak after Isabel, as it may be just this sort of the beginning of better communication, because without the well-educated health workforce, we'll never achieve the optimal and safe healthcare, but also will be unable to achieve the fantastic goals of EU4Health work program. So it is really difficult to talk about education and healthcare without mentioning the overshadowing pandemic. We are all the time drifting through this Kubler-Ross grief cycle from the moment the pandemic started towards the new normal that we don't quite well know how may look like. And during this difficult journey, we could see the complexities both from the patient's perspective, the healthcare perspective, health systems perspective, and also educational systems. What was at the very beginning very clearly seen, this digital exclusion of certain populations with access to health systems shifting towards digital care, towards telemedicine, in fact, is much more difficult. It is a lot of it includes a lot of structural violence, up to social deaths of people who are disconnected from societies now, mental health problems, health workforce prejudice against certain populations, stigma, and generally the burden of biosocial factors affecting health that we could hear about at the beginning of this meeting. Also, at the same time, COVID revealed the long existing weaknesses of health workforce education. And I think this is a sort of advantage that we cannot avoid this discourse for any longer. For a very long time, the education was stuck in this illusion of central position, which means let's only fix things if they are really broken. Let's don't implement a significant change because it's just okay as it is. And no, it is not okay as it is. If we are only fixing things when they are broken, we are really on the way to a very spectacular catastrophe. So we need to be aware that we are educating future and current health workers who will work effectively, who should work effectively in the context we cannot predict because it's in the future. Majority of standards of education change before even students graduate. And currently, the systems of education are really rigid. They are rigid because of many regulations regarding the quality, the standards, the quality assurance, but they are not adaptable. So today, talking about midlife and older women's health report, this is it's a very good moment to say how difficult is the way to implement the results, the recommendations from this report into the educational systems. Because currently, our systems in Europe are stuck between the licensing requirements, distance learning requirements, and so on and so on. And even last year, during the WHO Europe session at the AMI 2020 virtual conference, we started talking about the need to make the European health workforce curriculum more proactive, more responding to the needs of the population. And I think a very good example for this is to mention the European program of work of WHO, but we might also use an example what Isabel was talking, the EU for Health program. So looking at this WHO program of work, look what are the flagships. The flagships are so much related to what we are talking about when we're thinking about when we talk about women's health. It's a coalition for mental health, it's digital health, immunization, it's leveraging behavioral and cultural insights for health. But similarly to the EU for Health program, I may ask the question, how many of those goals, flagship initiatives, how recommendations are really implemented in our curricula, or our curricula are still stuck in 20th or 19th century? This year during the conference, we're discussing the shifts toward digital education, but also we're discussing the education for primary healthcare in Europe, which is absolutely fundamental for providing care to women, to all genders, to all age groups in Europe. Currently, the focus on factual knowledge prevails over focus on holistic attitudes and professional values in education. And we know, unfortunately, that empathy starts decreasing during the medical studies. So we need this very strong shift towards focus on professional values, on patient-centeredness in education. And we need to remember that innovation is not necessarily based on technical inventions. On the opposite, very often, especially now during the pandemic, all our efforts go into developing new technical media, new technical innovations, and we forget that in all this shift, we lose patients, we lose human beings. So we need to remember, and you can see at the top right, this graph showing the complexity of social suffering of patients currently. We need human-centered innovations in education. That's why last year during the European Union Innovation Days, I suggested using the term inclusive innovations in education. Starting from last year, AMI, and I represent AMI for WHO Europe, started talking during the WHO Europe Regional Committee meetings about the need to focus on patient-centeredness, communication, intercultural skills. And this year, just a week ago during my statement, I was drawing attention to need of increasing the role of patients. And this includes women, of course, this includes older people, patients and populations as partners in designing and implementing education. And as AMI is now developing the European Health Workforce Education Network, this is really great to work with the European Institute of Women's Health to bring these important aspects to the newly developed network. Also for the special ministerial event at the Europe RC71 last week, I was drawing attention of the participants to the fact of going beyond the individual silos of professions. Because currently we are learning in separate, we are teaching people, we are learning and assessing future health workforce in separate silos of medical education, nursing education, and so on and so on. So we need this coherence, and we need the coherence between the undergraduate and postgraduate and CPD education to make it a common construct with the future for the health workforce working the future and current health systems. I want to just mention two very important initiatives, the WHO Academy initiative, changing the approach to lifelong learning opportunities for health workforce, and our Pan-European Leadership Academy for public health professionals. And again, we need to discuss it, how to bring the outcomes of this meeting to these huge initiatives. So we need interprofessional education for interprofessional practice. We need bringing patients as partners into health workforce education, not only talking about patients first, but just simply, if you do something for me without me, you do it against me. And we need transformational change leadership, including focus on health care for women, for older people. So to summarize, both education and healthcare are so-called complex adaptive systems, and we need to tackle them from this systemic perspective. So we call in theory of education that we play infinite games. So it's not that this meeting will end and we'll happily go home that we presented our presentations. No, we need to all the time focus on bringing the outcomes of this meeting, of the other meetings, focus on women's health, on generally on health for European populations to education. So you might expect me to talk in particular about how many hours of lectures on gender medicine we should bring to European education. What I was talking about is the complex constellation of education that needs to be all the time remember when we talk about strengthening the health care for women, for older people, for all European populations. So again, that's why I'm very happy that we are here with representatives of the European Parliament, of the Institute, because we need to start working together when we talk about all investments in healthcare in Europe. Thank you very much.
Oh, thank you. Thank you very much, Janusz. That was very interesting. And as always, I really love your slides because I think they keep us all engrossed and you keep us interested. But I love the slides and the graphics on your slides. So thank you for that. One question. Do you think that gender medicine is properly addressed in the European curricula? You know, and how do you think we could promote it? You know, the need for bringing focus on women's health to the workforce education?
Well, honestly, I don't think that gender medicine, women's health are properly implemented because of two reasons. One reason is that there is still not enough of explicit courses addressing this issue. But I would say the major problem is not explicit courses like lectures and classes. The major point is to address the culture of institutions, the culture of health workforce, because without this, there is a duality. You know, we may give the best lecture on gender medicine, but if students do not see this working in the context of the healthcare, of primary healthcare, of hospitals, then it's not working. So we need to remember about addressing both explicit curricula, but also culture, hidden curricula to make this coherent. And what can we do? I think we are already, we started working on this. Just the fact that we talk about education during such meetings, and also the fact that, of course, the Institute is bringing this theme to AMI, to many other European organizations, that both you and Peggy start working with WHO Academy. And again, that I hope will, because currently there is this separation of people who are focused on health systems, healthcare, and on education. And we need to bring it together. Otherwise, it will not work. Thank you.
Absolutely. Thank you very much, Janusz. Thank you very much. And hopefully we'll have further discussion later. Just our final speaker, I suppose, of today is Rona Gaynor. And I'd like just to introduce her. She is a senior manager in the Irish Civil Service. She joined the Department of Health in 2016 as the head of the Policy Strategy and Integration Unit there. And the unit has successfully completed a lot of work, and certainly on the introduction of a sugar tax, which is very important in the whole diet and obesity issues, improvements in youth mental health supports, and the redesign of sexual assault services, and the introduction of artificial intelligence and robots in the health service. Rona has a role of the Women's Health Lead, convening the task force in partnership with the European Institute of Women's Health. So over to you, Rona, and thank you for being here today.
Great, thank you very much. Can everybody hear me? And are the slides visible, Tom?
Yeah, there's a little black bar at the top. You must have something overlaying it.
Okay, is that
that's-
just, okay, I think that's just the Zoom.
Okay,
function
so
coming up.
if that doesn't obscure anything, then you're good to go.
Okay, great. Great, thanks very much. And thank you, Maeve, for the introduction. I thought I'd just give a sense this morning. I know we've presented at previous meetings with the Institute of our work on the Women's Health Task Force, which is progressing well in Ireland. So I'll give you a sense of our overall progress, but with a particular focus on some of our recent work listening to women across Ireland, and some of the messages coming through for us for that midlife cohort, which I thought might be interesting given the report today. Women's health is a policy priority in Ireland at present. There's good recognition that women have specific physical, mental and social health needs. And we know, and again, there's good recognition that outcomes and experiences in the health sector are affected by women's roles within the family and society. It's a priority for our government. It's in the programme for government at present to improve women's health. And it's strongly supported by our budget and Budget 2021, which saw the introduction of a Women's Health Fund for the first time, which was a very significant development for us. There's a huge programme of work underway, covering any number of issues as they might affect women and with that gender lens in health, around maternity, sexual health, cancer screening, the termination of pregnancy service is a new introduction in Ireland, and several other big initiatives which the Irish health sector is leading. The Women's Health Task Force began in 2019, and that was with a view to trying to bring together those initiatives, which were very much happening in different parts of the sector, and try and bring them together and integrate them and set that strategic framework for where Ireland might take some leadership around women's health. You can see here, this was our day one, September 2019, pre-COVID, so no masks, very different collaborative setting for us that we hope we will all return to soon, of course. But you can see there, the photo says a lot in terms of our membership. So a strongly partnership-based model. And we have a lot of participation from staff within our ministry. And that's to try and get good, joined up whole of government working. But lots of significant participation from key partners across the health sector, our health service, key specialist institutes that involve general practitioners and specialists, and a lot of involvement of advocacy groups in our work. So that's made it a very deliberative forum and a very inclusive forum, which has really shaped the direction of the programme. This, I hope, will work, and it'll just give you an overview. So you can see there just a flavour of what we've been doing. These are the priorities that are set out for our first phase of work. And our vision was always that the task force would work in partnership to focus on a small number of priorities, move those ahead, and then move on to a revised set of priorities, keeping that relationship to listening to women to help take those decisions. And for the purpose of today's meeting, I thought I'd just share with you some of our work listening to women about health and healthcare. So we've done a significant piece of research led by MCCP, an agency in Ireland, to listen and engage with women in respect of their experience of healthcare in Ireland. And that report was published last week and can be read in detail. But some of the highlights of the report I've just included here. So for many, experiences with healthcare are very positive. Factors that shape that positive experience for women include maternity care, GP services, acute care. So women experiencing, listening and empathy within our maternity services, really appreciating that engagement with the mother. Our GP services, women really appreciating that proactivity, that trusted relationship with your general practitioner. And again, in our acute and screening services, that sense of proactivity coming through, that it was very tailored, that it's an opportunity to reflect on health coming through very strongly for women. We also, though, saw in this research, in this listening work, this sense that women feel the healthcare system is underserving their needs. And there were a couple of big themes that came through in this research. So a sense that information and conversation can be very limited. Women telling us that they felt unsupported, they didn't know the steps ahead in the journey. Women often telling us that many of the issues, the women's health issues that they wanted to talk about, they still felt, a stigma attached, shame and embarrassment about raising some of those issues. Women who participated in this research in these workshops told us that they often didn't feel as an individual in our system and felt that their voice didn't matter. We also learned a lot about women and the sense of women carrying the greater burden in Irish healthcare services. So the sense of a responsibility for caring, a responsibility for coordinating the care for anybody in their caring circle, and the inequity of that came through very strongly in the research. But we also heard about an out of touch system and a desire for more visibility of women, practices to move forward, different ways of communicating, and a more joined up experience. For 46 to 60-year-olds, which was one of our cohorts, I thought I'd just take you through quickly at a high level of some of that feedback. Again, it's in the report, which we can share with you. A lot of the women who participated in this in Ireland told us that they felt they were entering this challenging life stage with a lot of change and uncertainty ahead. This sense of their own health coming to the fore for the first time. Women in this phase were telling us about their interactions with healthcare were very much around kind of specific topics. So the menopause, bringing women into the healthcare system quite deliberately, GP again, and screening services, bringing women into the health system at this point in their life course. Women in our groups, as part of this research, gave us the feedback that menopause is seen as very secretive, it's not spoken about, a sense that there's very low level of understanding. Women are very dependent on their own network and peer networks, be it friendships or family, to give them information around the menopause. And this sense of it feeling kind of secretive and closed, and that contributing to taboo and stigma. Some of the women at this workshops showed us that in their experience, their mental health needs were often dismissed, and that there was a focus on the physical challenge and less of a focus on the mental health needs. And women who participated were telling us about experiences of feeling very unsupported generally by society at this phase in their lives. Health issues for older women. Again, we got that feedback that these weren't discussed, the practices weren't evolving. So a sense coming through from the workshops and the research that there was a disinterest in women's health for older women, like bladder issues or pelvic floor issues that were spoken about earlier at the meeting. And some of the women participating telling us that they felt there was an expectation to simply get on with things. So again, some really interesting kind of perspectives and experiences coming through. In our older again cohort, our 60+ cohort, there were some other messages coming through. This sense that how women view themselves has evolved considerably. So, you know, women's healthcare is viewed through the lens of changes in society. So this sense that there is greater value placed on women's health and women's healthcare possibly than before. So a positive coming through there. A sense that women in this cohort in our national context were giving us that sense of not having the language or the confidence to interact with healthcare professionals in the way that possibly different generations do. So feeling that frustration, but often unable to voice that. And that has an impact then on healthcare needs and their partnership with health professionals. For many in this age cohort, they were describing significant caring duties continuing into this phase of life, that their own children are becoming very dependent on them as a childcare resource for the next generation. And so this kind of physical impact of that caring duty continuing right on across this age cohort. So you can see from the research and from our work in the task force, a lot of different issues coming through from engagement with clinicians and advocacy groups and health stakeholders. A lot of the issues facing midlife and older women are featuring in our agenda for change. And that's something that we'll be looking at now very closely in how we present a path forward for women's health, which is reflective of the life course, which is reflective of the issues that occur at different stages, as well as reflective of the different situations that women find themselves in our country, the different socioeconomic situations, etc. I showed you at the outset our day one picture. Of course, like all of us, we were on Zoom as we launched last week. But again, I suppose it's just an image that conveys it. In our first image, we had our Minister for Health very much leading the charge on women's health, providing that leadership and sponsorship. And we've had a change in minister, but no change in that leadership and championing of women's health. So again, our minister led the publication of that report and will be leading several changes in the months ahead. So we're 700 days into our program and getting stronger day by day. The task force is very much working and has been working through the last 18 months virtually and digitally and finding new ways to move the program ahead. And we're very much focused now on taking that input from the listening exercise and making sure that that's very real, very lived in our program and that it connects to policy in a very direct way. So we have a number of inputs that form a part of our evidence base. There's a dedicated piece of work around women's health in Ireland, which again, we've published and can be made available to anybody on the call who would find it of value. Which just sets out some of the Irish data disaggregated by gender to illuminate women's health. The radical listening work and the report of that work was published online. It's very transparently available, all of that feedback. And that's a process that we hope will continue with us as the program emerges, that women are very much participating in and responding and helping us to shape the program as it moves ahead. There was a discrete piece of work led by our National Council for Women and Girls, very much focused on marginalised women and making sure that that voice is heard, equally heard in our programme, and that those pieces of feedback come into the policy design as well. And that's was published last week and can be seen. And of course, pieces of work like the Institute's EU manifesto are of course informing our thinking as well. So we've got a very strong evidence base now emerging with Irish evidence around women's health, which is important. We've got issues that have been raised through extensive consultation. You'll have seen in the video, more than 1,200 women participating in the program so far, and we hope to just grow that number as the program develops. We know that there are kind of known gaps and pressures in our services, and so that's informing some of our future direction. Government priorities, of course, leading us forward as we shape the agenda for the next year. And of course, we're very keen that that set of priority areas that I mentioned at the beginning, we have a job of work to do to embed those, to continue to grow those, that work around menopause and gynecological health, and to keep that active as we move into implementation. So our opportunity now is shaping the programme for 2022, keeping that energy and momentum with us, taking all of those inputs. We feel very well educated now on women's health in Ireland. So our job is to bring that together and to build a focused and a prioritised and a funded plan of action on women's health in Ireland. And we hope that that'll come through our government in autumn this year and shape a very active and dynamic programme for 2022. So thank you for inviting us here today. Very interesting to hear the discussion so far, and happy to take any questions.
Thank you so much, Rona. That was really, really interesting and interesting and good to hear about that took part with the external groups. Can you hear me okay? Yeah. Just to say that, there was obviously a lot of work carried out there with external groups and extensive sort of stakeholder input, which is obviously very, very important for, and as you said, a lot of the women felt silenced in various. Just one question, Rona, do you think that EU member states could replicate what has been done in Ireland?
I think there's a model there of working, which is to partner together and not to seek. I think one of the interesting things about what we've done is we haven't sought to specify every action, every requirement from day one. We've very much tried to pick, priority areas, look at them collaboratively, and then, take stock and select a new set. So it's a very different way of doing policy making. I think this is open policy making at its best. And we've had a lot of inputs, and I can share the link to our program of work, but every conversation we've had is online and has that opportunity for people to input and shape it. So yeah, I think there's a lot that could be learned. Of course, we are always looking internationally as well, and we have a lot to learn from others. And I know Austria and other countries have done some very interesting work in this space as well. But we're certainly proud of what we've done.
Yeah, well done, Rona, and a lot of work gone into that. So thank you very much for participating today. And I'd also like to thank all of the speakers really today, from Sirpa and Teresa and Janusz and Isabel, because I've learned, you always learn something at the webinars, and I know it's a new way of working for us. We normally have our conferences in Brussels, and it's really great that we can do the webinars. I'm sure there are questions, and I think
Sirpa,
there are.
Sirpa would like to ask a question, Maeve. Sirpa?
What I was going to do was hand it over to you, Peggy, and maybe we could just do the discussion together. Would that work with Sirpa's question? And maybe if Rona could join the panel, would that be possible, or is that going off? Sirpa, perhaps.
Thank you, and thank you for excellent presentations. My first reaction is to thank you. Second is to ask, could you please make the PowerPoints available? This is to all of the speakers, and if you could send them at least to me, but I'm sure all the MEPs would be interested about them. Then the third reaction is that I'm sketching on my head already the program on EU level, and that then on my thinking sort of has three parts. One is the societal backgrounds that we had the first intervention. Then the second is the actions needed, the sort of what we know already and the needs for data and so on. And the third, and I really would like to thank you for the Irish presentation. And I think that this is an excellent participatory model what you have. Could we create a program alike that we could sort of push and start pushing towards the Commission that it should be launched and financed? So thank you very much.
Thank you for that contribution, Sirpa. I might hand over now to Peggy if we have any other questions. I know we have collected, amalgamated the questions over the last hour and a half. So will I hand over to you now, Peggy?
Thanks very much, Maeve. Thank you so much. And thanks for all our speakers. They're excellent. I think they've given us sort of I suppose, a little platform now to move us forward into our panel discussions. And I'd like all my panelists to put on their cameras, but keep muted at this moment in time. Irona and all the other speakers, very happy if you could join as well. I know you may want to leave, Rona, but if you want to, very happy to have you join. I think moving backwards, I think Rona has set the scene for us I think the Irish example is a really good model, and Sirpa, you're absolutely right. I think this model should be adopted at a European level, and I think the Irish Department of Health can advise on how we could transform this and transfer it in the EU member states in the context of individual member states. So I think that's important that we look at that. But I think, yes, I agree, Sirpa, that I think that's something that should be looked at because it's an excellent model. I think Yanis has shown that in Rona's presentation, she showed how women felt they weren't listened to and how the health systems were failing them. And I think Yanis, again, we should really take cognizance of what Yanis is doing, because he is looking at a crucial element of care, and that is medical and workforce education, the health workforce education. Because if we can have all the policies we want, but we don't have an educated and well-informed health workforce, I think we're wasting our time, basically. And I think Isabel has set the scene with the finances. We all need to look at now how we can avail of the EU for Health programme. And I know it's very much targeted at member states, but I mean, even this could help Rona and all the work that she's initiated in the Department of Health, which I think is completely unique. I have not seen it elsewhere in the European Union, and I think she needs, and we need to support what's happening in the Department of Health at a European level. So if all my panelists are there, I'm going to begin now. Miriam, are you there? Just to say that most of the people on the panel are the expert reviewers who took the time to look at this report and to make excellent comments to the report from their own expertise. We have one person, Anna Londrot Sunjan, who is an expert advisor to the European Commission in DG Research. She didn't review the report. I just wanted to make that clear, but I'm delighted that Anna's here. She's just had to have an input from her expertise and exactly from the European, from the Horizon Europe new programme. So Miriam, can you put on your camera, please, and also put on your microphone, and I can ask you, just from the basis of your experience now with this report, I have a specific question for you. Are you there, Miriam? Oh, good to see you. So Miriam is Professor for Intercultural Psychiatry and Psychotherapy at Charité Berlin, and she's also a board member of the European Psychiatric Association and chair of section on transcultural psychiatry of the World Psychiatric Association. She is also the focal point for the European Institute of Women's Health work in Germany. And we've been working closely together for the last number of years. And we are hoping, we have our plans, Miriam, to work further on women's mental health moving forward. And we do look forward to that. The question I have for you, Miriam, is as a board member of the European Psychiatric Association and your work with vulnerable women, which I know is very extensive, particularly with migrants, what do you think are the main priorities to be considered regarding midlife and older women's mental health?
Thank you very much, first of all, for the invitation to this really very important panel and audience. I'm very happy to be here. Thanks again. I think that I would like to start with, just a second. I have a, yes, now. I would like to start with a citation from WHO, where is written that there is no health without mental health. I think this is a very important point to be sure that there is mental health recognized in all issues of health. So because many health conditions increase the risk for, sorry, I have a small problem with, okay, now. Technical problem. I don't know. Okay. There is, again, many health conditions are very important in the case of, I don't know. Sorry.
Ariam, we can see and hear you okay.
Okay, thank you very much. I would like to have a look to my points, which I noted. This is my point. So, okay. I can tell it so. For example, all mental health issues, for example, depression was mentioned by a few speakers before. Depression is one of the main causes for up to 40% of lives lived with disabilities. And we know that per year, 20 million people in Europe, maybe 7% of all people in Europe get depression. 1 in 5 women and 1 in 10 men develop depression. And this is, I think, a huge issue to be recognized and to be understand, because depression is, for example, mental health condition which has huge impact on also other mental health disorders, but also somatic disorders. For example, it increased the mortality in circumstances with cardiac disorders. For example, as twice higher when in comparison only with major depression. Another issue is that suicidality and depression goes hand in hand. We know that depression multiplies with suicidality in people up to 20%. So it's a huge issue to have also suicide prevention issues and treatment possibilities. Another very important point is that more than 50% of major depression is not well treated or untreated. There is a lack in knowledges in, for example, primary healthcare parts of healthcare systems. We should improve the knowledge on depression and how to treat depression or other mental disorders, not only in the part of mental healthcare system, but also in other parts of healthcare system. Another point which I would like to underline is that depression is, for example, a risk factor for dementia. And dementia, as you know, is a huge challenge for the future, because we know that a lot of people, also elderly women and also men, develop dementia. And looking to people with migration background, we have evidence for high impact on risk factors. For example, one is depression, but also living conditions. For example, poverty, for example, less education, food issues and so on have huge impact on developing on, for example, vascular dementia, not Alzheimer's dementia, but other kinds of dementia. And we see that these dementia are developed in an earlier stage of life, maybe 10 years before in comparison to natives in these countries. Another point which I would like to underline is the drug-drug interaction. If people or women, men in elderly lifetimes have comorbidities, for example, diabetes, hypertension, or other kinds of comorbidities, and have to take drugs, there is a huge impact in drug-drug interaction on their life quality, well-being, but also adverse side effects and so on. So we know that it was mentioned by a speaker before that historically the trials with medication or drugs was done with men. So we have to be aware of all these issues, and we need a lot of more research and of course also funding and so on in these aspects of mental health care. So there are a lot of other issues. One maybe maybe the last one, international migration is a huge point which is less seen in healthcare system. There are a lot of lacks of access to healthcare, mental health care, but also these risk factors have huge impact in developing mental health disorders, for example, depression, as mentioned before, dementia, but also psychosis. And I like the talk of Janusz, because intercultural competence or competencies in different healthcare professionals and to go together and to work together, it's very, very important. So to be able to support the mental health issues of these people are a main focus, or should be a main focus two. One last issue which I would like to mention is that also during the COVID-19 pandemic, these vulnerable groups were really in very bad conditions and had also less access to healthcare issues, but also in vaccination issues. So we should also be careful dealing with them and have much more focus on ethical issues. So to treat people fairly is one of the main principles of ethical issues.
Thank you very much, Miriam. That's an excellent presentation. And, you know, depression is such a huge issue for women. And, you know, what we forget is that illness can cause depression as well. And our next panel member is Antonella Cardoni, another reviewer of the report. Antonella is the CEO of the European Cancer Patient Coalition. And also before this, she was the executive director of the Fit for Work Global Alliance. Antonella, as CEO of one of the largest cancer patient NGOs, the EIWH has highlighted there's still inequities for women in accessing treatment for cancer. Do you think that the EU Beating Cancer Plan, the European Commission's Beating Cancer Plan, will make a difference to women in Europe?
So thank you, Peggy, and also thank you to the European Institute of Women's Health for organizing an event on such a relevant topic, and for inviting me, as I consider this a timely and excellent topic for discussion. As the report highlights, women are the main users of healthcare and the main providers of that care. And of course, one of the biggest challenges facing European societies is maintaining health in light of an increasing aging population. At EU level, we are now undergoing a momentum, and we need to make sure that we, women, work together with the EU, governments, NGOs, etc., to ensure that European women have the chance to live in good health, and we considerably reduce the existing burden related to disabilities and disease. And the report shows statistics on cancer being the main cause of death among women aged 50-64 years, accounting for 52% of all death in this age group. And the second highest cause of death in all women aged 50 plus and older. So furthermore, we should highlight that among the gynecological cancers, risk of ovarian and uterine cancers increase with age, with most cases being diagnosed after menopause. So breast and cervical cancer screening programs are strongly associated with a reduction in cancer mortality. EU member states have developed screening programs, for example, for breast and cervical cancers. However, cancer screening and treatment for new and ongoing illness has been adversely affected by the impact of the pandemic. Therefore, the time is now. We all together need to take action. Aspects such as raising awareness, educating women in prevention, early detection and treatment are key. And we need to inform women, so to empower them as well to spread the knowledge on best practices. That is the way forward. And let me conclude with something I consider to be very relevant. As the report suggests, we need to encourage young girls and women and let them know that they do have a say, and that working on patient-centered approaches, we can develop higher quality healthcare for women, especially for the disadvantaged women. Therefore, here, empowerment and interdisciplinary collaboration are essential words to be forward. And to be put forward. And the Europe's Beating Cancer Plan is addressing all those issues. So we are hopeful that the Europe's Beating Cancer Plan will address and will implement all these issues so that the gaps between different countries when it comes of women treated of cancer will be, if not totally filled in, at least will be decreased. So thank you.
Thank you very much, Antonella. I know I've just got a message from Deirdre Clune, who's to finish. I know we're running late, actually. Deirdre was to give us conclusion. I don't know whether you're still there or not, Deirdre, that you could say a few words before you go, but I don't know whether you are or not. No. But she was going to finish off first, but I can do that on her behalf, if that's okay with her. So next, I'd like to come to Claire Champet, who is the policy officer in Eurocarers, who really at the end of the day, I mean, we have to look at women who are not just patients, but maybe when they're patients, they're also having to look after their families, etc. Claire, and what I'd like to ask you is, it is usually midlife that women have a huge care burden. What would you like to see policymakers do for carers that will reduce inequalities for this population group?
Just a very big thank you for inviting us to participate in this report and for this fantastic presentation and event. I think it's a much needed report, and it's especially because it's really shed light on the care responsibilities of women as a factor of health and well-being, as having an impact on well-being. Very often we speak about care responsibility in relation to women's participation in labor market. And I think the impact on their health and well-being is much undermined very often. The reality, as we know as an organization gathering more than 75 research and carers organizations across Europe, and is that most of the care is provided by women, and especially when it's intense care, with a tremendous impact on their mental and physical well-being, especially when this intense care is not supported by a lack of information, training, formal care alternative, respite care, etc., etc. We have adopted a few years ago a strategy for informal care in 10 steps, which try to embrace what would be needed for a care-friendly society. And we have been promoting this strategy for several years, which has been inspiring some member states to put in place a comprehensive strategy for carers. But much remains to be done, because very often action are taken, but in a way that remain piecemeal and insufficient. With the pandemic, the situation has been further exacerbated in many countries. More care, more intense, with less support, more stress, more impact on wealth and on health and well-being. I'll put in the chat some links to a report that we've been finalizing lately on the impact of COVID on carers. To be short, we have to be certain that the carer issue is here to stay. It's not something from the past. Given the demographic, given the stress and the sustainability of the long-term care, the limits that we've seen during the pandemic of the institutionalized care for older people, carers are here to stay. And the question of balancing care and life remain as an issue for the next years. So that is why we were delighted really to hear by President von der Leyen that the Commission is going to put forward a strategy for care. We very much expect this to be covering at the same time social, health and long-term care altogether, formal and informal care. I mean, the global question of health care workforce, as rightly underlined earlier, that it would be centered around the needs of user and the community, based on partnership across all policy area involved, and be inspired by what we've been working on, building and listening to carers, bringing their voice in the debate and the research. We've been invited yesterday in a meeting by the Spanish government, who is willing to prepare a strategy on care, together with 3 ministries: health, employment, gender equality. We very much hope that same is going to happen at the EU level, that this issue is going to be considered as really cross-cutting, with streamline across all relevant area. And especially, I take the opportunity of the presence of DG Santé. We believe that there is room in the new programming period for action for carers, for the health of carers. And we've been involved in discussion around it, but we don't see exactly where and how this can happen. But please believe that it is an important aspect of health prevention if we want women to gain years in health, in good health. So that's,
thank you very much, Claire.
yeah.
That really gives us an
Very
insight as to what's needed from a policy perspective. And I think really from that perspective, I'll move over to you, Anne, and Anna from Anna Schulden from DG Research, Anna Londra Schulden. She's advisor to the director in DG Research. And I know you were previously head of the Union for Healthy Lives in Europe 2020, which I think was a fantastic program. The Commission has launched the Horizon Europe program, Anna, and the previous program had a specific focus on gender and aging. Is this the case, do you think, in Horizon Europe?
Thank you very much, Peggy, for that question. And I'll try to be very brief, although it's difficult because we do a lot of the things that are related to women's health and also to aging. But just to put your question into the context of what's different from the past, is that really we moved on to say to those who used to do research for us, producing papers and publish them isn't enough anymore. You need to look not only at what the research output is, that your result, but also the outcome. Who is going to do something useful with your results? And that whole fundamental change in perception and the need for applicants to actually identify the utility and how the results are going to be used is really penetrating the new program. And in designing the objectives and the aims, we've had a major involvement of the citizens and many rounds of consultations, and we want actually patients and citizens and other relevant players to be involved in the research in the future. We're talking multidisciplinarity much more ambitiously than ever before. We have new types of initiatives, which is, I would like to mention the missions, which are really, I would say, ambitious, target-oriented, time-limited goals of achieving something really tangible in this limited amount of time. And we have the cancer mission. The cancer mission is really closely married to the Europe Beating Cancer Plan, and they really talk to each other. And what the cancer mission does is providing the research and innovation support that the Europe Beating Cancer Plan needs. That's just one example. Then we have the partnerships with member states, for example, but also with another one with industry. And then partnering with member states means that you can leverage on and also organize your funding programs in EU and the member states, so you can get so much more money for a given objective. We have one very exciting one, I think, in this context coming up soon, which is transforming healthcare systems and modernize them. And of course, the gender aspect needs to be taken into account there. Other things that have been mentioned here, what I think are really essential is the mental health. We have a very ambitious topic open for research and innovation now in the next round of topics. And on the mental health, we really want to recognize the impact from COVID, but not only that, also the climate anxiety and the negative aspects of the IT use on sort of mental health. So there are many openings there. Talking about COVID, we've had a lot of research support raised very quickly to address the biological aspects, vaccines, therapeutics, diagnostics, and so on. But we also did a major action on socioeconomic impact, and particularly targeting the vulnerable groups, including healthcare workers, women, and so on. So we've done a lot to provide research and innovation support to address these issues. Another thing that has been mentioned here is obesity. There's a great opportunity there as well, coming now soon in the next year work program here. So what I like to say also generally, not only in these items that I mentioned, but across the board, the gender dimension needs to be there. It's an obligation, and you can no longer sort of ignore it. And I think that is another very important aspect to underline here now. So what I would like you to do when you think about this from the research and innovation point of view is to think, what is the unknown question that we, not unknown question, what is the unknown answer for which we have a question that's not answered, and spell out what is the research and innovation needs that we have. And there one can contribute, step in with the knowledge and the and sort of the competence and the resources that you have, and step into a context which is really multidisciplinary. Not everybody needs to be a medical frontline researcher. There are many different roles in there, particularly when we talk about this outcome-based activities and not only output. So I think, I know it's getting late, so I could dwell into, you know, all sorts of details on all these things I mentioned, but I think those were the main things that I wanted to contribute. So thank you very much again for this very inspiring webinar.
No, thank you so much, Anna, as usual. Thank you so much for your input. I'd like to come to Heidi next. Dr. Heidi Schiller is a psychologist and a senior scientist working at the Gender Medicine and Diversity Unit in the Medical University of Innsbruck, Austria. She has published extensively and taught on various topics around violence, among other things, and presented her work nationally and internationally. Heidi, as an expert in sex and gender issues, what do you see as the important issue for midlife and older women post-COVID?
Thank you very much. Also, a big thank you for me for organizing such an inspiring event and putting together so many great people to share our thoughts and ideas. I would like to connect a few things that have already been mentioned by the previous speakers, and also bring in that we need to consider the timeframes. And I think Anna also pointed it out when talking about the outcome and output, that we have to think about short-term goals, but also midterm and long-term goals. We don't have to, we shouldn't forget that. I'd like to focus on three main aspects. One would be the impact of the measures that have been there to contain spreading the virus, especially for midlife and older women when it comes to isolation, lockdowns, to restricting movements, for example. How do they impact health? How do they impact social activities? And we have to consider now is how do we cope with it, and how do we introduce structures to get people out of the isolation, especially older women, and especially if they're also involved in caring responsibilities. A second aspect, which also connects to what Janusz was saying previously when he said that COVID revealed shortcomings of the healthcare worker education, it also revealed quite striking inequalities between genders, and it also exacerbated inequalities between genders. And I think we shouldn't forget that. We shouldn't get them covered again, but we should really focus on it as well. We've already heard about the informal care, women as carers, women as frontline workers. We need to consider these aspects, their roles, and how they impact their well-being, their life, and also the health of women. And in this context, we need to talk about poverty, employment and unemployment, how it affects women, and also the gender pay gap. We also heard that in Teresa's presentation about the health report, where she connected also poverty and working conditions. And this brings me also to my third aspect, which I just want to talk about very briefly, which would be violence against women, especially violence against older women, because it's still an aspect which is underreported, and it's still under-researched and under-recognized. We need to put more focus on it, especially when we think about how symptoms of abuse sometimes get confused with aging and symptoms of aging, that we need to disentangle it, that we need to focus more on it, and to address the gaps in research. And we need to consider that there are intersecting dynamics with age that we need to address. And overall, we heard about vulnerable groups and disadvantaged groups. We should also think that we are not talking about one homogeneous mass of women, but we need to address the diversity within women, starting with age, but also, for example, a migration background, language, roles that they have to fulfill, sexual orientation, for example, gender, that we're not only talking in binaries, but also consider gender in all its breadth and diversity. And we need to look at structural and societal levels, how they intersect with individual inequalities that are resulting from these structures. And yeah, so we really need to focus on all these intersecting aspects as well, and keep the complexity and not reduce it too much. So that was just very briefly, just acknowledging the time and the time pressure that we're on. And again, thank you very much, Peggy.
Thank you very much, Heidi, for your fantastic input. And last but not least, we have Barbara and Fifi, who have been working for a huge number of years on the issue of aging, and they're two huge aging advocates. For example, Barbara has been a Swedish politician, has been a member of the Riksdag since 2006, and she's done a huge amount of work on with WHO and the Drug Dictionary and the WHO Programme for International Drug Monitoring, and it was a pioneer in the field of pharmacovigilance. And Fifi has done a huge amount of work on with the social pillar and looking at I think integrated care and looking at long-term care as well. Based on our time, Barbara and Fifi, I wonder, could you just combine? I know you've done so much work with aging and age platform, and we thank you so much for the review as well of the document for our report. But we'd like to hear from you as experienced people working on aging. You've worked for many years on the board of age and on advocacy in different organizations. What can you take from the report? What do you take from our report regarding midlife and older women's health that you reviewed?
I think the first figures that we got with the differences between member states, we have to deep dive into them, see what is behind them. And for instance, I saw that there is one country not screening for mammary cancer. And so we have to learn what we can from what is behind all these figures. The other thing I caught here is really the human aspects of meeting patients and seeing to it that older women are not met by ageism. As a patient, but also as carers, because healthcare is now moving out from hospitals into people's bedrooms, and therefore you have to have a patient-centered care, but you have to include also the closest relative, the spouse here, in bringing knowledge, also technical advice and all these things, because they are just supposed to help their husband or their wife without any actual training for it. So but because, well, also their ageism is hitting. I think also one thing in this digitalized world, I meet now older people who say, I want to talk to a human being. And I think that has to be brought into healthcare and care in people's home. Time to talk, not only to connect with their laptops. And I think also on a whole, to include older people, they are individuals, not a collective, and listen to all their experiences in views. And this comes through not only for women, but also for men. And one thing I think was marvelous to listen to, and that was what they do in Ireland with this to involve all these women in order to improve the situation of women, and as a consequence also for children or for husbands and so on. And I think I'll stop here because I know we are half an hour late.
I don't know whether Fifi wants to follow on with you. I don't know whether Fifi, you'd like to say something before we close?
Well, just a little bit. Thank you for hearing all your presentations, especially the one from Ireland I love. But there are three little things I want to mention what I didn't hear yet. That is the dental health. I never heard about that. And for migrants, they're not included in all kind of proofs and clinical trials. They're never in there, and they don't get, that's the other thing, they don't get interpreters when they go to the doctor. They have to take their own family with them, but not a real interpreter who can tell the real reality they want to tell. There are three things I want to bring in, just to be short.
Thank you so much, Fifi, and thank you all to our panel. It's just an amazing amount of information and expertise that's come through today. And I'd like to thank all of you for the review, at the time you've spent reviewing this report. We very much appreciate your expertise and the time that you spent as well. I know, Anna, you didn't, but I always respect and really appreciate the advice and the information that you give us. Unfortunately, Deirdre Clune couldn't make it, and I will ask Sirpa in a few minutes to close for us. But just to say that, Maeve mentioned earlier that prevention is so important and health promotion should be a focus, which it isn't really for member states. And that's what we have to look at if we're looking at resilience in the future. I know our report mentions issues like vaccination. It's one of the most effective ways to combat morbidity and mortality from infectious diseases across all age groups, as well as influenza. Vaccinations are available in Europe for other disease areas as well, affecting older people, including pneumococcal, herpes zoster, diphtheria, tetanus and pertussis. So I think we need to be cognizant as well that there's health promotion, disease prevention is crucial. From a life course perspective, we have to start and intervene early and right from the start and get it right from the start. And issues like osteoporosis and bone health as well, which is a huge issue for women, where we have 5.5 million men were estimated to have osteoporosis in 2010, with 3.5 million new fragilities. So even if it affects men, so we're not just talking about women here, it's a huge societal issue as well. But on that note, I really, I can't thank all the speakers enough. Maeve, I don't know whether you want to come in here now as well, put on your camera. I'd like to thank, there's a number of people I would like to thank. I'd like to thank Sirpa, of course, for hosting our event. She's been a fantastic advisor and support to the Institute over the last 25 years. And Sirpa, I will ask you to finish in a minute. But I'd like to thank the sponsors today for supporting our event. And I'd also like to thank Mary Pat McGrath, who is an Irish artist who has done some illustrations for the report. And the report will be available in a couple of weeks on our website, as well all the other information and PowerPoints. I'd like to thank Maeve for the excellent chairing and all of our speakers, of course. I'd like to thank Marlene, who's here as well, who's been Trojan work over the last couple of weeks in supporting our event, Teresa for doing the research, and Hilary, our company secretary, for supporting the event as well. And last but not least, Tom Duke for his patience in managing all the technology, etc., which it can be quite daunting at times. But Sirpa, can I call on you to bring the meeting to a close, if you're still there? I think she's probably gone, is she?
Probably.
Sirpa? I think she's gone. Maeve, did you want to say anything in conclusion?
Just thank you all so much. And I feel totally energized from this webinar, and I hope everybody else. And I'm really looking forward to progressing all of this work. There's a lot to do.
And as Heidi said, if we all work together, wouldn't we make it a much better world for midlife and older women's health?
That's the aim.
So thank you very, very much.
Okay.
Thank you so much. Take care of yourselves, and thank you for all the time you've spent today to support this event. Thank you and goodbye. Bye-bye.